School of Wisconsin, Pediatric Hematology Oncology Department. She's an associate professor of the Medical College of Wisconsin in Milwaukee. She graduated from Tufts University School of Medicine in Boston, Massachusetts. Dr. Veronica Pella did her pediatrics residency at Phoenix Children's Hospital and her pediatric hematology oncology fellowship at Oregon Health Science University School of Medicine in Portland. She's board certified in both pediatrics and pediatric hematology oncology. So welcome her. She's going to talk to us about coagulation issues.
Thank you. Thanks for the kind welcome. And on a day like today, I kind of wish I was back in Phoenix. I swear it was summer in Milwaukee when I left this morning. So I don't know what happened. So I was given the charge of talking about coagulation disorders, and I was told people had a specific interest in both bleeding and thrombosis. So I have tried to combine them all. So it's going to be a little bit of a whirlwind tour through problems with clotting factors. This is probably a little bit more pediatrics based because I am, as mentioned, a pediatrician. So I apologize to all the non-pediatricians in the audience, but hopefully there'll be something useful. And also please jump in if you have questions. I thought I should disclose my potential conflicts of interest. So I do have research funding from NIH. I have no other financial conflicts of interest. And I have a couple of medicine uses that are not necessarily approved for all ages or all the possible uses I'll be discussing, which is predominantly antifibrinolytics. So I'll try to remember to touch on that when I get there. Okay, so outline, the first half of the talk is going to be bleeding disorders. So a little bit about laboratory testing, and then von Willebrand disease and hemophilia are the main ones I'm going to talk about. Platelet defects is up here just to remind me to say that due to trying to cram too much into an hour, I've really taken out platelet defects from this talk, but just remember that there are a lot of problems with platelets that also cause bleeding. And then we're going to talk about thrombotic disorders. So specifically, congenital thrombophilia, laboratory testing, which is I think the thing we get questions about the most, what to do for these kids, and then a little bit on acquired thrombophilia, because this is also a problem. All right, so clot formation. Obviously, we all need to make blood clots to survive. This entails there first being an injury to the vessel wall. Then the next step is that you get platelet aggregation, which occurs at sites of injury. The fibrin clot is initiated via the coagulation cascade. The clot is then stabilized by factor 13. And then eventually that clot is digested via fibrinolysis. And you can have something go wrong at any step of this process and have bleeding, or if something goes wrong in the opposite direction, you can have excessive thrombosis. So how do we look into this? Well, we're looking for patients with bleeding symptoms. And the way we tend to teach medical students is that coagulation factor defects are generally deep tissue and muscle bleeding or joint bleeding. So these are the more severe types of bleeds that you see. You can have delayed bleeding episodes, you can have recurrent bleeding episodes, but that's more typical of a coagulation factor defect. If you have a platelet defect or a defect in a clotting factor like von Willebrand that's associated with platelets, this tends to be more immediate bleeding. This is where you see skin bruising, mucous membrane bleeding, epistaxis, easy bruising, menorrhagia would be another common symptom with platelet-type bleeding. So the big question then is when you're faced with one of these patients, what do you do? And there are a number of screening tests that have been touted. So CBC, obviously one reason we do that is to check and see what their platelet count is or if they're anemic. PT and PTT, which are common coagulation factor screening tests. Mixing studies to prove that it's a defect in a specific factor. And then the two that I'm going to put lines through are bleeding time and the platelet function analysis, which have been done to diagnose bleeding disorders, but neither have optimal sensitivity or specificity. So unfortunately, once you get through the regular screening test, you're stuck looking for more specific problems. And I'll talk a little bit more about that. So the PT-PTT, this is your traditional clotting cascade. This is where you have the intrinsic pathway, which is measured by the PTT, and the extrinsic pathway, which is measured by the PT. And I think this is useful if you get a prolonged PT or PTT and knowing what clotting factor might be deficient. In reality, this is more complicated than this nice simple diagram, and then all these factors feed back on each other, so it's really more of a circle than a nice waterfall. But at least in terms of our screening test, this diagram works reasonably well. Platelet function analysis is a super popular test. It's a whole blood test that looks at the ability of platelets to occlude a membrane that is impregnated with platelet agonists. So for those of you, and probably many of you already know what this is, but in case anyone isn't super familiar, with these results you get back a collagen ADP answer, and then sometimes they'll also give you a collagen epinephrine answer. And that's just referring to what that membrane has on it. So you suck up the blood over this membrane, and the result you're getting is the time it takes to clot off that membrane. So this is very easy to perform. The machine looks like a little coffee pot. Suck up the blood, you get an answer in 15 minutes. This is probably why it's so popular. However, this is the sensitivity for platelet disorders, which is anywhere from 80% with a really well-selected population down to 25%. And sensitivity for von Willebrand is more in the 50 to 70% range. So this is why we don't necessarily recommend performing the platelet function analysis. There's a couple of reasons. One is just that platelets are very sensitive, delicate little creatures, so if they get disturbed on their way to the lab, and a common way this happens is a lot of labs where you get the labs drawn, they will send the specimen via a tube system, which upsets the platelets, and you can either get false positives because the platelets have exhausted themselves before they get to the lab to do the PFA, or you can possibly even get a false negative where you have somebody with a mild bleeding disorder, but the platelets have been agitated just enough that when they get to the lab, you get a normal PFA. So there may be other reasons to do this. The most common reason I do this is if you have a really little kid with severe bleeding and you want to rule out a severe platelet problem. But if you're using it to screen for a mild bleeding disorder, I'm just warning you that the accuracy is not where we would like it to be. Okay, so the first bleeding disorder I'm going to talk about, and this is my favorite one, so I will try not to use my entire time period talking about von Willebrand disease. But this is von Willebrand disease. This is the most common inherited bleeding disorder and is probably the most challenging to diagnose. So this is a disorder where you have defects in the von Willebrand factor protein. And part of the reason it's so complicated is because VWF has two different functions. The first thing it does is help stick platelets into place. So it tethers platelets to injured blood vessels. It has a binding site for collagen and a binding site for platelets, specifically platelet glycoprotein 1b. And so it helps that platelet stick near where the injury is. It also serves as a carrier protein for factor VIII. So in that function, it actually is serving more in the regular clotting cascade. This actually has been shown to affect about 1 in 1,000 individuals and presents with mucosal bleeding. So this is primarily because of its function in tethering platelets. You'll typically see patients have epistaxis, menorrhagia, easy bruising, and it's diagnosed with a personal history of bleeding. These are typically autosomal dominant for most forms, so there'll be a family history of bleeding, and then abnormal VWF testing. The big problem here, especially in pediatrics, is that mild bleeding symptoms are not uncommon. So little kids tend to get bruises on their shins, and that's normal. Many people have nosebleeds, so it can be difficult distinguishing what is normal kid bleeding versus what is truly abnormal bleeding. And there have been a lot of efforts to quantify people's bleeding, but what seems to be the most relevant for von Willebrand disease is the number of areas in which you have bleeding. So if you have somebody who has easy bruising and nosebleeds and is a teenager and has heavy periods, I would be much more suspicious of that person than a kid who just has a few bruises. And then similarly, it's also a little bit the extent of the symptoms. So if you have somebody who has nosebleeds during allergy season, and they all last 2 to 3 minutes, I'm going to be less worried about that kid than somebody who has a year-long history of twice-a-week nosebleeds that last for half an hour to an hour. the screening tests for von Willebrand disease unfortunately may not be helpful. They may have a prolonged PTT, especially if the factor VIII is low. They have about a 50% chance of having an abnormal platelet function analysis. And when we used to do bleeding times, they might have had an abnormal bleeding time. Maybe in adults this is easier. In kids, when you do a bleeding time, you make a incision on their arm. You blow up a blood pressure cuff so they have a specific pressure down there, and you time how long it takes to stop bleeding. And your average little kid does not like sitting there watching their arm bleed, so this is why we don't do bleeding times anymore. Screening tests, therefore, do not rule out von Willebrand disease. So you are stuck with having to do a bunch of different tests. And most hospitals will have a von Willebrand disease panel of some sort. This usually includes the von Willebrand factor antigen. This gives you how much von Willebrand factor is there. Von Willebrand factor activity, which is usually done as this ristocetin cofactor activity. Sorry, I'm pointing at my screen, which doesn't help you at all. And historical antidote, ristocetin was an antibiotic. It happened to cause thrombocytopenia. The reason it does this is it causes VWF to latch onto platelets and they get cleared from the circulation. So it does not make a good antibiotic, but it makes a great diagnostic test for von Willebrand disease. We also do recommend doing a factor VIII activity. There is one type of von Willebrand disease where it just affects the ability of the von Willebrand factor to bind factor VIII, although usually those patients would also show up with a prolonged PTT. And then, of course, von Willebrand factor is not a simple protein. It's actually this huge multimeric structure. So when you have a normal individual, which is the one on the far right, you will have dimers, tetramers, 6-mers, 8-mers, 10s, 12, 14, 16, et cetera, et cetera, et cetera. If you have a mild deficiency, which is a typical type 1 von Willebrand disease, everything will be there, just a little bit fainter than the normal. However, there's some variants where you don't make normal multimers, so that's a couple of the type 2 variants, and you can see they're missing the ones at the very top. These are the longest multimers, and so you can imagine those are the most important hemostatically. This might be anthropomorphizing a little too much, but I like to think of the VWF as a lasso. It binds to the collagen on the blood vessel that's been exposed, and then it goes out and grabs a platelet that's in circulation and brings it in. So the longer that multimer is, the better it's going to be at bringing in platelets. So the higher molecular weight multimers are the ones that are more useful. So I thought I would spice things up with a case presentation. So this is a real von Willebrand case. 14-year-old who had normal PT, normal PTT. Her CBC showed a normal platelet count. She was a little bit anemic because her history was heavy menstrual bleeding since menarche. So this was somebody who was basically, her periods only lasted for 7 days, but she was going through a pad every 30 minutes to hour, and they were soaked. So some teenagers will say they're changing their pad every 5 minutes because there's a drop of blood. This was somebody who really was soaking through the entire pad. She also had a history of epistaxis, so she would get these nosebleeds that could last even up to an hour, and a history of easy bruising. And this was somebody who was more of a bookworm. This was not somebody who was out playing soccer or other sports. In taking the family history, it turned out her mother had actually had a hysterectomy done in the past because of heavy menstrual bleeding. So both mom and the daughter ended up having a diagnosis of von Willebrand disease. Their von Willebrand factor levels were around 40%. Normal goes down to 50%, so still pretty mild, but enough to give them significant bleeding. Not necessarily life-threatening bleeding, but definitely affecting her quality of life, especially with the menorrhagia. And then going back and historically diagnosing mom, unfortunately, mom's heavy menstrual bleeding had never really come to attention, and she ended up requiring a hysterectomy. So, von Willebrand disease is a problem because there's 3 different types. Type 1 is just a deficiency of the protein. You make it, it's just not there in enough quantity. So it's a mild to moderate quantitative deficiency. You have proportional low levels like antigen of 28, activity of 25, or antigen 41, activity of 43. Type 2 is a qualitative defect. you make the protein, but it doesn't work in some way that it's supposed to. So it doesn't bind platelets, or it doesn't bind factor VIII, or it doesn't bind collagen. And there, you have an antigen that may be low or may even be normal, but the activity is significantly decreased. So my example labs here would be an antigen of 28, but an activity of 12. This could also be an antigen in the normal range, say an antigen of 60, but the activity could be 20. So this is unfortunately why we're stuck doing all these different assays to diagnose von Willebrand disease. And then type 3 is the most severe. So this is where you have undetectable von Willebrand factor. Treatment, generally with mild cases, we actually use desmopressin. You can also use this for mild hemophilia patients. It comes as an intranasal form. You can just squirt it up the nose, and we use this a lot for women and girls with von Willebrand disease and heavy periods. Just be careful, the version that's used for bedwetting is much more dilute. It's 10 micrograms per spray. If you're using it for von Willebrand disease, you want the concentrated version. There is also a von Willebrand factor concentrate we can give if we need to, and then antifibrinolytics, Amicar or Lystata. This is aminocaproic acid and tranexamic acid, and Lystata is approved for anyone with heavy periods. And then symptomatic treatment, so actually estrogen tends to work really well for women with menorrhagia, even if they also have von Willebrand disease, and if they're iron deficient, iron happens to be the treatment choice for that. Just a word about antifibrinolytics, and this is probably not news to you guys, but I think they're such a great drug that I want to remind people that they exist, and they work for a whole bunch of different types of bleeding. So these work by inhibiting plasmin. So you have your fibrin here, and ordinarily you would have your plasminogen that gets activated and binds, but both Amicar and tranexamic acid prevent that from happening, and so you have basically stabilization of the blood clot. So I put dosing in here for anybody that wants to know, and Lystata is the easier one to use for menorrhagia because it's only TID, and they inhibit plasminogen. And they work for all sorts of mucosal bleeding. So if you have bleeding with oral surgery, we use these a lot post-tonsillectomy, and then the other big area is women with menorrhagia, or adolescent girls with menorrhagia. All right, so a few words about hemophilia. This, for anyone that was not grandfathered in and has to recertify for boards, this is very prevalent on the boards, even if not necessarily in real life. Also known as the royal disease, and I include this just because it's fascinating. The Queen Victoria was a carrier of factor IX deficiency, not factor VIII, which is the more common one. So anyone that has factor IX deficiency, hemophilia B, you can claim you're related to Queen Victoria. So factor VIII deficiency is hemophilia A. This is more common. Factor IX is hemophilia B. This is less common, but they tend to present the same way because, as you remember from medical school, these two proteins complex together. So there's 8 is everything except the purple. 9 is a little protein, 8 is much more complicated. And that may explain why factor VIII deficiency is more common. These are X-linked. It's X-linked recessive inheritance, but I also want to point out that 30% of factor VIII deficiency patients we see are new mutations. So just because somebody doesn't have a family history of hemophilia doesn't mean that the baby you're seeing with post-circumcision bleeding couldn't be affected with hemophilia. So an example case here, this is a recent baby that came from northern Wisconsin. The baby was born premature and had bleeding every time they tried to do a heel stick for the newborn screen. And they actually had to abort the circumcision because when they went in to inject some anesthesia, the sites they were injecting started oozing all over the place. To the point where this baby actually had a hemoglobin of 8, and the PTT turned out to be 150 seconds. So this is not a diagnostic dilemma. It's probably some sort of hemophilia. And he turned out to have a factor VIII activity level of less than 1%. This was a spontaneous mutation, so no one in the family had ever had hemophilia. Unfortunately, the factor products we used to treat hemophilia in the 80s, there was a high rate of HIV and hepatitis transmission. So we're now seeing a generation of young women whose fathers had hemophilia but passed away, and the young woman, who's now the mother of the baby, doesn't know about her family history of hemophilia. So we've also had a couple where there was a family history, but the mom of the baby didn't really know that much about it because her father had passed away so many years ago. So hemophilia is divided into 3 categories. Hemophilia is much easier than von Willebrand disease. It's either severe, moderate, or mild. And severe is very, very, very low factor levels. So these are patients with less than 1% factor activity. And if you don't do anything to treat, they will have spontaneous bleeding. We now put these patients on prophylaxis, but if we didn't, they would have an average of 1 to 2 bleeds per week, and those are generally joint bleeds. Typically knees and ankles, but it can be any joint. Moderate hemophilia is people whose level is anywhere between 1 and 5%, and even that low level is enough to protect you. Typically, these people will have bleeding with minor injuries, can be on average of once or twice a month, but not as frequent as the severe hemophilia patients. These types are generally diagnosed in childhood, so highly unlikely any of you that are adult treaters out there are going to run into one of these without knowing it. But mild hemophilia can actually present in adulthood because these patients tend to bleed only with trauma or with surgeries, and they have much more rare joint bleeds. Their factor activity is anywhere from 5 to 40%, so people on the higher end of that range who don't happen to be involved in football could get to an adult age and have their first surgery and end up with bleeding after that. But the severe ones are all going to present as kids. And diagnosis is going to be a prolonged PTT, but a normal PT or INR. For the mild hemophilias, my little diagnostic pearl here is that not all the PTT reagents are super sensitive to mild factor IX deficiencies. I don't know about your lab, but I know at Children's, ours is much more sensitive to 8 than it is to 9. So having a normal PTT, particularly if this is a workup for a major bleed or in some of our child abuse workups, we will do a factor IX if the PTT is high end. The mixing study, when you mix this patient's plasma with normal plasma, it will correct because having 50% of factor 8 or 9 is enough to give you a normal PTT, and that's officially defined as normal. So you will have either low factor 8 or low factor 9 levels. If you have a newborn baby that's bleeding all over the place and you don't know which it is, you have a couple of options. If you have access to the actual factor 8 and factor 9 products, we have occasionally just given them both. Statistically, it's probably 8, so you could get away with cryo or give plasma. But most of the time, if it's not a new mutation, we can trace back who the affected family member is and know from there. So diagnosis, we do the factor level to diagnose the boy. And we'll also often do gene sequencing for mutation analysis. This is because of the risk of inhibitors. Since these patients haven't seen factor 8 or factor 9, they can make antibodies against that protein. And if you have antibodies or inhibitory antibodies to factor 8, that makes treating you with factor 8 much more difficult. We do recommend C-section if we have a potentially affected male infant, or at least no instrumentation for those deliveries. And if the mom is a carrier, there's a 50% chance of inheriting hemophilia for each of her male children, and a 50% chance of being a carrier for each of her female children. However, carrier status is difficult because, as you just heard, normal factor 8 goes down to 50%. So often we will do gene sequencing to determine if a girl is a carrier. And unfortunately, although we try to do this and try to do education, there are carrier women out there that don't know they're carriers, or who just had a factor 8 or factor 9 level done that was at the low end of normal and somebody told them they weren't a carrier, and they can still deliver a baby with hemophilia. So I developed a high level of suspicion of anybody that has a family history of hemophilia and tells me they're not a carrier. Also, if their dad had hemophilia, they're an obligate carrier, because the dad, if she's a girl, the dad had to give his affected X chromosome to her. So no matter what she says, she's a carrier. So keep that in mind. Okay, treatment. This is a really fun era for treatment because we're doing a lot better with our hemophiliacs. Treatment strategies for mild or moderate patients, we give them factor when they need it. But for severe hemophilia, we strongly recommend prophylaxis. This is where they get factor, depending on the half-life of the factor, anywhere from once a week to 3 times a week. But we are getting better at making factors with longer half-life, so this is going to go down to twice a week for factor 8 to every 7 to 14 days for factor 9. Complications are that, unfortunately, these factors are all IV, so they need IV access. Compliance with oral medicine, maybe not all that great, but it's even more difficult with medicine that you have to give IV, and these are expensive. And as I mentioned, the bad medical complication is inhibitors. If you start making antibodies to this replacement factor, then we can't use that medicine to treat you anymore, and we have to go with bypassing agents. There are a ton of new treatment options. We all have, for hemophilia, we have recombinant factor that doesn't involve plasma at all, so theoretically, no disease transmission. We have the newer, longer-acting preparations, which for factor 9, some people are out to an infusion once every 2 weeks. And so that's very doable in pediatrics without putting a port in. No matter how little the baby is, you can do an IV poke every 2 weeks. You can't do an IV poke twice a week or 3 times a week. So those kids will often need ports. There's also some novel drugs that aren't factors, that are factor mimetics, where you give them either IM or sub-Q. And there's also gene therapy in adults. So we have a few adults now who have been cured of their hemophilia with levels in the 40s and 50s from gene therapy. It's still a very new field. Nobody's out very far, but the first study has 5 to 6 year follow-up, and they're still doing well. So not approved in pediatrics anytime soon, but for those of you with adult patients, this is an option. And it's really interesting. A lot of these patients that are going through gene therapy are the grandparents of boys with hemophilia. So a lot of them aren't doing it for themselves. They're doing it very altruistically so that they can prove gene therapy works for their grandson. So that's kind of cool. Treatment, if it's an emergency, infuse factor immediately. And we try to give all these patients these instructions, but just be aware if you end up getting the call from them that if they think they're bleeding somewhere, then it's recommended that they get factor. If they're in an emergency room, we recommend doing factor for severe injuries before you finish doing the scans. So if you think somebody has a head injury, we'd rather you get factor first and then go to the CT scanner. If we're wrong and your head is fine, you just got a little extra factor. If we're right and you do have a head bleed, we'd really prefer you got the factor sooner rather than later. Factor 8 deficiency, I don't know how many of you are actually going to have to dose this, and I should remind everybody that we have a physician phone line, which I don't know what the number is offhand, but you guys probably all know it, where if you end up with one of these kids in your clinic or hospital, feel free to call so you don't have to memorize the dosing. But factor 8 deficiency, the emergency dose is 50 units per kilo. Factor 9 deficiency, it's 100 units per kilo. There are about 7,000 different factor products right now. So you may start seeing patients come through that are on new and improved clotting factors that are supposed to have a longer half-life. But if it's an emergency, whatever you've got in your pharmacy will work, as long as you're giving factor 8 to the factor 8 deficient patients and factor 9 to the factor 9 deficient patients. And I hope your hospital is better than ours. I should stop doing anecdotes, but our Epic makes you order it by name. So hopefully you guys can just order factor 8 or factor 9 and then things will pop up. Because I think that's much safer for emergency treatment than trying to remember which name goes with which product. Okay, so any head trauma or neurologic symptom in these kids merits immediate evaluation. And as I said, infuse factor first before scans. Be aware in these hemophilia patients, compartment syndrome can happen after relatively minor trauma. So that's just another thing to be aware of if you're seeing one of these kids. And we also recommend factor before any invasive procedures. The problem, severe hemophiliacs know this, moderate probably know this. Some of the mild patients have such few bleeding symptoms that they will forget about this and go get things like their wisdom teeth pulled without factor. So we recommend treatment beforehand to prevent those bleeding symptoms. If it's mild hemophilia, you can give desmopressin. Desmopressin increases your release of stored VWF and factor 8. So obviously that's not going to work for a severe hemophilia restored factor VIII, but many of the mild patients we can get away with just desmopressin before minor procedures. So other clotting factors, since I was supposed to cover all of coagulation, factor 11 deficiency is super uncommon. This is autosomal recessive. It is very frequent in people of Ashkenazi Jewish descent. And it's a little problematic because people can bleed if they're heterozygote for factor 11 deficiency or if they're homozygotes, and the bleeding tendency doesn't necessarily match what their level is. Factor 12 deficiency I'm going to mention because this will result in a prolonged PTT. If you're homozygous, the PTT can be 200 seconds. If you're heterozygous, it might just be 40 or 50 seconds. But it is not associated with clinical bleeding. And if you remember back to medical school, the index case with this actually died of a PE. So it probably does have something to do with coagulation in the body, but if you see somebody with a low factor 12, they do not need treatment. Factor 13's function in life is to cross-link fibrin clots. So you can have a factor 13 deficiency with a normal PT and a normal PTT. This is also fairly uncommon, so you may never see this. We only have a couple. But the typical presentation is delayed bleeding. And for anyone like me who has to keep recertifying for their pediatrics boards, the classic presentation is umbilical stump bleeding, poor wound healing, and the mom may have a history of spontaneous abortions. And then women with this can also have significant menorrhagia. You can have deficiencies of any of the factors. Factor 1 is fibrinogen, 2 prothrombin, 5, 7, 10. There's also a genetic defect in the way factors 5 and 8 are cleared, so you can get a combined defect with both 5 and 8. And I should also say, technically, these are referred to with Roman numerals. I am using the regular numbers for them because especially when you start talking about 9 and 11 and 12 and 13, they all start to look alike. And yes, accuracy is important, but I'd rather we understand what we're all talking about rather than use the professional numbering system. Maybe you guys are better at Roman numerals than the people I work with. So here's just for your reference. Most of these are autosomal recessive except for factor 8 and 9 deficiency. And except for these two, these are like 1 in a million frequencies, which is not to say you couldn't see one at some point. So these are my clinical pearls to throw in. Coagulation disorder testing, CBC, PT, PTT. If you really suspect somebody has a bleeding disorder like von Willebrand's, you need to get the actual von Willebrand panel. If you're really concerned that they might have a mild hemophilia, I would go ahead and just do that factor 9 activity, and then other specific coagulation factor testing as needed. In terms of treatment, symptomatic treatment, so women with menorrhagia, hormones are a great choice. Iron if they're iron deficient. We have specific factor replacements for a handful of these conditions. So we have specific factors for 8, 9, 13, factor 7, which is NOVO7, and then von Willebrand factor. Desmopressin works for mild von Willebrand disease, type 1 patients, or mild factor 8 deficiency. Antifibrinolytics for any fibrinolytic defect or for mucosal bleeding. And then beyond that, you're looking at plasma, or cryo for fibrinogen 8, 13, and von Willebrand factor. So that's kind of my workup and treatment for all of these things thrown together. All right. I want to use the last few minutes I have to talk about thrombosis, because I was also told that was a subject of interest. Clotting in children is relatively rare. Those of you that see adults, it's very common in adults, but less common in pediatrics. Hospitalized children are going to be at higher risk, and most pediatric thrombosis is unfortunately related to the presence of central venous catheters. You have smaller veins, a large piece of plastic. In a sick kid, it's just not a good combination. And the highest risk is during the neonatal period. And some of this is due to Virchow's triad. You have hypercoagulability. Neonates haven't developed all the anticoagulation proteins yet. You have endothelial injury from a big catheter somebody put in the femoral vein or whatever. And stasis from whatever their underlying illness is, you get a clot. And this is a study out of Canada that actually shows this huge peak in the neonatal period. So this is the number of children. I think they had 150 maybe approximately thromboses that they investigated over their study period, the vast majority were under the age of 1. Fewer in young children, and then it started going up a little bit in adolescents, but still the majority were the babies. I think it's also important to note, though, that these are sick kids. These aren't generally healthy kids. So a third of them had a central line, and almost all of them had at least one underlying medical condition that predisposed them to thrombosis. In terms of thrombophilia testing, I would be remiss if I didn't point out that there are actually guidelines through the American Society of Hematology. This is their Choosing Wisely campaign, where they recommend against thrombophilia testing for adults in the setting of major transient risk factors. So in English, this means if you have somebody in the ICU with a major infection and a catheter and they develop a catheter-related thrombosis, you probably don't need to go looking for factor V ligand. And we practice very similarly in pediatrics. If there's an obvious reason why you got the clot, we probably aren't going to do a big thrombophilia workup. The other point is that inherited or acquired thrombophilia does not necessarily predict who's going to get recurrent catheter-related thrombosis. And unfortunately, anticoagulants also aren't good at preventing recurrent catheter-related thrombosis. So what we recommend is to consider testing for adolescents with an unprovoked clot. And unfortunately, we do see occasional adolescents that come in with no risk factors and even with pulmonary embolism. Or if there's a strong family history of thrombosis. So here are the thrombophilia risks with the common ones. This is antithrombin deficiency, AT3, protein C, protein S. And these all carry a very high risk of thrombosis, on the order of 3% per year, and such that people who have these conditions, at least half of them will probably experience a thrombosis during their lifetime. Factor V Leiden and prothrombin gene variant are much more common, but you're also much less likely to have a clot. And with these, the clot is much more likely to occur in a situation where you have some other systemic illness at the same time. So when we do thrombophilia testing, our first line is to do the major ones. These are the more severe thrombophilias, so AT3, protein C, protein S. And if there's a family history or an unprovoked clot, absolutely looking for these is justified. Factor V Leiden, I just want to mention there's two different tests. There's a genetic test, which looks for the specific genetic change, or there's an activated protein C resistance test that looks for the effective factor V Leiden. I'm assuming none of you do this, but in Milwaukee, we have a lot of people that order factor V Leiden testing as a factor V activity. These are not the same thing. So we have flagged our lab if somebody orders a factor V activity to ask, do you want factor V Leiden? Because that's much more common than factor V deficiency. But just be aware, if factor V Leiden is your question, it's either factor V Leiden genetics, a DNA test, or it's the activated protein C resistance that will get you the answer you really want. For the prothrombin gene variant, your only choice right now is doing the genetic testing. And I also should mention the caveat that this is genetic testing. So occasionally people find out things about their family genetics that maybe they weren't aware of and maybe didn't want to be aware of. So if you have a parent that is homozygous for factor V Leiden and tests their kids and none of them have it, that can be an issue and vice versa. So there have been some reports. I've never had one, but there have been reports where information has come up through these tests that people have not really wanted to know about. Okay, and really when you do these, what you're most worried about is a homozygous state or somebody who's a compound heterozygote. So heterozygous factor V Leiden alone or heterozygous prothrombin gene variant alone are very low risk. If you're heterozygous for both of them, that's going to bump your risk up. And if you're homozygous for one of them, that's going to bump your risk up. So those are the things we're most worried about. And again, test if there's a family history or an unprovoked clot. That being said, the biggest reason to get a clot is because you have a history of a previous clot, and having a family member with a clot increases your risk of thrombosis no matter what other inherited conditions you have. So once you've had that clot, there's some inherent risk factor in the family that we can't put our finger on. So for anyone that ever has a question about putting girls or women on an estrogen-containing medicine with a strong family history of thrombosis, this is why we'll often say if there's a strong family history, I don't care what the tests show, we prefer that person not be exposed to estrogen. The other acquired clots can come from antiphospholipid antibodies. So these are not inherited. That's actually my next bullet point. This would be your lupus anticoagulant, your anticardiolipin antibodies, or anti-beta-2 glycoprotein 1 antibodies. And having more than one of these categories increases your risk of thrombosis. So that's another part of our testing we do for unprovoked clots. But since they're not inherited, we don't necessarily do them for a family history. And then the very exciting thing I want to end with is treatment options. So our old model for treatment of thrombosis was to start somebody with Lovenox or heparin as an inpatient, bridge them to warfarin, and occasionally in pediatrics, particularly in neonates, because warfarin is so difficult to manage, we would just do their entire course of treatment with Lovenox. There is a new model out there, so those of you that are adult treaters probably already know this. There are the new direct oral anticoagulants. So these are the common ones, generic names and brand names. These would also be the brands you see ads for on TV. There's usually an ad for how wonderful my life is on this drug, and then another ad, and then an ad for the lawyers saying if you have blood on this drug, please call this number, we can give you money. They are approved in adults. Their approval is pending in children, but we are close. So in pediatrics, let me talk about the adult data first. So right now, all the analyses of the adult data prove that the direct oral anticoagulants as a group are at least as safe as warfarin, if not safer. We all have patients who have bled on one of them, but we probably all also have patients who have bled on warfarin. One of the big worries has been that the direct oral anticoagulants cannot easily be reversed. For heparin, we have protamine. For warfarin, we have vitamin K. I would say that we have a reversal agent for warfarin, vitamin K, but we also have horrendous bleeds on warfarin. So practically, the relative unavailability of direct reversal agents hasn't been that big a problem. And there are now reversal agents for both of these categories. They are ridiculously expensive, so many ERs won't stock them or you need to get approval to use them, but they exist. And all of the meta-analysis data is that they're at least as safe as warfarin. With the exception of cardiac patients, AFib, I think warfarin is still the treatment of choice, and antiphospholipid antibody syndrome. So a couple of minor exceptions, but your standard catheter-related thrombosis, regular DVT, PE, they are indicated for. In pediatrics, we actually have studies for 2 of these, which is really exciting because pediatrics usually doesn't have evidence-based data. Rivaroxaban and apixaban both have studies. The rivaroxaban study was just, the results were made public this summer. The ISTH is the International Society on Thrombosis and Hemostasis. 500 children with acute venous thromboembolism received 3 months of rivaroxaban treatment. In this cohort, compared to the children that received standard therapy, which was Lovenox bridging to warfarin, there was less thrombosis burden, less recurrent DVT. The only downside was that there was a slight increase in what they call non-major bleeds, but there was a decrease in major bleeds. So if this data pans out, I think almost everybody would take this trade-off, that you have a drug that's given orally, and they made a liquid of this. So this could be very, very small children taking this. And again, I have no affiliation with this drug company. I just hate warfarin. So that's my intellectual conflict of interest. But an increase in non-major bleeds, I'll take if it decreases the major bleed rate that we see with warfarin and the horrible complications. And the not needing to be poked for a shot or not needing to go in every week or so to the lab for testing. Okay, I'm a couple minutes late, I think, but hopefully you'll forgive me. So in patients with bleeding history, suspicion of a coagulation factor defect is warranted. I still screen with a PT-PTT, but my take-home point is be aware that normal results don't rule out a factor deficiency. Specifically, the one I'm thinking of is von Willebrand disease, but it also doesn't rule out factor 13 deficiency. And treatment, we have specific factor concentrates that can be used to treat most of these conditions. And then the other take-home point for thrombosis I want to leave you with right now is for the workup, base it on the specific history. When I started, we were doing thrombophilia workups on everybody. And so this is a sea change in the way the thrombosis field has been working, but the indication right now is that really it would be an unprovoked clot or a strong family history, and that the kid with sepsis and a femoral line does not necessarily need a full workup. And they're at much lower risk of recurrence than somebody else. Acknowledgements, and I think I want to just end with my contact information. If you do have questions or want to chat, I would be happy to hang around for a while afterwards if people have specific things, or if you're one of the local pediatricians, I would love to meet you because I see your patients and it's nice to put faces with the people that I'm calling up with weird and wacky results, particularly on their von Willebrand screen. So thank you, and I'll be happy to answer any questions. Or I'll just hang around back here. And I totally understand everyone who has patients waiting for them to answer.